what is Group B strep? So Group B strep, or Group B streptococcus, also called Group B strep, GBS, it's basically a type of bacteria that lives in the large intestine. So GBS can migrate from the intestines to the rectum, the vagina, and the urinary tract. So GBS is generally considered a normal part of the microbiome, and it usually does not cause symptoms of illness in the person carrying it. So this is not like a sexually transmitted illness or anything like that. It's just a normal part of your microbiome, and a lot of people carry GBS. About 10% to 30% of people who are pregnant carry GBS in their digestive tract. So worldwide, approximately 18% of moms carry GBS, although rates may range from 8% to 35%, really depending on the location, because this really depends on, it differs where you are in the world. The global estimates that I'm talking about, these come from Russell and colleagues in 2017. So GBS is not considered a sexually transmitted infection, like I mentioned, and there's no evidence that GBS is spread through water, food, or surfaces like that. So GBS can sometimes cause infections during periods where a person's immune system is more vulnerable, like infancy, older age, or if you have a chronic illness. Otherwise, GBS is not harmful, and a lot of people don't even know that they carry it. So in pregnancy, GBS can occasionally contribute to a few different things. This is rare, but this can happen. So one is a urinary tract infection. It also increases the risk for preterm birth, and it also increases the risk for stillbirth. Today, in the rest of our training, I will be discussing statistics specifically on preterm birth and stillbirth and infant death. So that topic might come up. So just wanted to offer that as a trigger warning. So GBS causes approximately 1% to 2% of urinary tract infections during pregnancy, and approximately 1% to 2% of stillbirths. So these estimates come from Steer and colleagues from 2020. So now let's talk a little bit about how do we figure out if you have GBS? It's different depending on where you are in the world. There are a few different approaches. We're going to talk about all of that today. In the United States, screening is recommended between 36 weeks and 0 days and 37 weeks and 6 days. It used to be 35 weeks to 36, I believe, and then they changed it recently to 36 to 37. Testing closer to birth is intended to provide more accurate picture of whether GBS will be present during labor. So I think the reason why they shifted is because, and you'll learn about this more, we're going to talk about what the research has to say, but if you're tested with GBS in pregnancy, it is possible by the time you're delivering your baby, you actually don't have GBS present in the vaginal canal, because levels can fluctuate and change. So that's, I think, why they're wanting to do testing a little bit later on, hoping that it's more accurate. If we do it at 36 weeks, you don't have your baby till 42, that's a lot of time for things to change. I also wanted to share that if you ever test positive for GBS, you can test negative again. You can get retested if you want to. If you stay pregnant longer and you want to see if you still have it, you can always ask to be retested. GBS levels may change over time, and the person who tests positive at 36 weeks, it might be negative during labor. And so the goal is to obtain the results within approximately 5 weeks before birth. GBS is found in a urine culture at any point in pregnancy. The person is considered to be GBS positive and does not need their routine testing. Urinary cultures are common and part of standard care in pregnancy, and that usually happens in the first trimester or whenever you establish care. Those can often tell us if you are colonized with GBS. Colonized meaning there's a greater amount of GBS present in the urinary tract and it's showing up in the urine, in which case we know that your body has GBS, and right, so you can skip that test. So let's talk a little bit about the test and how it's performed and what your options are. So the test is a cotton swab. It's like a long Q-tip, and this should be inserted into the vagina, approximately 2 centimeters or 3/4 of an inch into the vagina, and approximately 1 centimeter or 1/2 of an inch through the anal sphincter into the rectum. As a student midwife, we would get out the whole kit, right, with the tube and everything, and we'd instruct the mom on what to do, and it's pretty simple. I think most people can swab their own vagina and their own rectum pretty easily. You just take out the Q-tip, you just put it right inside your vagina and do a little swish, and then just kind of like a little tap into your bum. It doesn't have to go very deep, just a little bit. This is going to potentially collect GBS bacteria if it's present, and it will show up in a lab culture later. So results can take about 48 hours. The swab must enter slightly through the anal sphincter for the most accurate result. So swabbing only the outside of the rectum may increase the risk of an inaccurate result. So people with a severe penicillin allergy should have the susceptibility testing performed to determine whether their GBS strain can be treated with other antibiotics. That's really important. So we can do a test and see your, strain of GBS, and then do susceptibility testing and just make sure that the antibiotic we choose is going to be effective for you. So GBS culture results can change because GBS levels naturally increase and decrease, kind of like how I mentioned before. So there was a study that I want to discuss by Young and colleagues at 2011. And so those who tested negative at 35 to 36 weeks of pregnancy, 91% of them remained negative during labor. So that means that approximately 9% became positive by labor, and those people didn't get accurate treatment, right? Or they didn't get counseling around that because they thought they were negative. It turns out by the time they went into labor, they actually became positive. Unfortunately, we'll talk more about the rapid tests later, but rapid tests are not very accurate. So for this study, they would do the swab and then they would look at the results later on. But since it takes 48 hours, it's too long. Baby will usually be here by now. So yeah. And then for those who tested positive at 35 and 36 weeks, 84% remained positive during labor. So that means 16% became negative by labor. So this means screening may result in both false negative results where GBS is present during labor after a negative prenatal test, and unnecessary antibiotics, where a person is no longer carrying detectable GBS during labor after a positive prenatal test. Now let's talk a little bit about self-swabbing. So moms may be able to collect their own GBS specimens after receiving instructions. Kind of like what I talked about when I was working at the birth center. We would give the mom the tube, tell her what to do, and she would go swab her own vagina. And so research has found that self-collected swabs can be reasonably accurate, although clinician-collected swabs are showing that they're a little bit more sensitive in a few studies. And so I want you to be aware of this so you can make an informed choice. First off, no one has to swab your vagina. I think for moms who want to be feel more private and they don't want to do cervical exams, and now they're at their 36, 37 week appointment, and the provider is saying, get on the table and undress from the waist down, and I'm going to swab your vagina. I'm going to swab your bum. Moms sometimes are like, I really don't want you to do that. Why can't I just swab myself? So the answer is yes, you can absolutely swab yourself. In some places, it's common practice to just swab everyone. In other places, like the birth center that I used to work for, it's common practice that we will support the mom in swabbing themselves. In the home birth practice for me, that I was in as a patient, I would swab myself, each time. I never had someone swab me. And so we have different studies that have different results on self-swabbing. And I think what's important to acknowledge is that you ultimately have the right to do whatever you want. And if you're like, I don't care if someone swab me, then that's great. But if you feel like they don't want that, then we should honor that and you should swab yourself. Just make sure if you're swabbing yourself that you're following the instructions appropriately. In some studies, we found that self-swabbing does produce lower, it's not as sensitive as the clinician. And then some studies show that it's quite lower than the clinician. And it's probably that in that group of people, they weren't getting proper instructions, or there was something like that going on. So in a study by Prince and colleagues in 2006, clinician collection approximately had a 96.9 sensitivity, and self-collection was 87.5 sensitivity. In a study by Araya and colleagues in 2018, clinician collection was about 94.3% sensitivity and self-collection was 84.3% sensitivity. And then there's this one study in Hong Kong by Cito and colleagues in 2019, and they found that clinician collection was 97.6% sensitivity, and then self-collection was 61.4% sensitivity. So that had a pretty big drop in that study. So the accuracy of self-swabbing really depends on comfort, it depends on instructions, and it depends on technique. But know that you don't have to have someone else swab your vagina, and your bum. If you don't want that, if you want to do it yourself, that is always an option that you have the right to, especially if you don't feel comfortable with that provider, with that person who's wanting to do the procedure, or not the procedure, who's wanting to do the test, the swab. So a standard GBS culture requires 1 or 2 days to process. So it can't be performed during labor, kind of like I mentioned before. And so let's talk about the rapid tests and why they're not used, because that would be great, right? Like if we're learning that if you are positive with GBS, there's an opportunity for you to actually not be positive, right? Like 16% in that one study we found did not have GBS that was detectable when they were actually in labor. So they received unnecessary antibiotics. So wouldn't it be great if we had like a rapid test that could tell if you have it in the moment? But unfortunately, there is one, but it has a lot of limitations. So one is that they're not as accurate. They also can take like 1.5 to 2 hours. And if you are wanting antibiotics, if you do have GBS, if you have to wait 2 hours, then we need 4 hours of antibiotics, you might have had your baby by then. They're also not useful during a fast labor, and research is conflicting on whether they reduce unnecessary antibiotic use. So they require a laboratory that operates 24 hours a day also, and not everyone has access to that. So rapid testing may be sometimes used for like preterm labor, missing test results, people who are not previously screened for GBS disease, in newborns or newborns that have immature immune systems, because GBS can cause serious illness, So there are basically 2 primary forms of GBS that we'll talk about next. So the first is early onset GBS disease. So early onset GBS disease occurs during the first 6 days of life. So this is defined as GBS being detected in the baby's blood, cerebral spinal fluid, or their lungs. The baby also will show signs of illness. So there may be sepsis or bloodstream infection, meningitis, pneumonia, and symptoms usually begin at birth or shortly afterwards. So early onset GBS disease is really serious, though it is really rare. And this is why we're doing all the testing and everything that I'm talking about today, is to help prevent any consequences from early onset GBS disease or reduce the risk of infants contracting it. So approximately 95% of infants with early onset GBS disease show the symptoms within the first 48 hours. And this is from Nanduri and colleagues in 2019. So research suggests that early GBS disease often begins before birth. So there's a study by Tudela and colleagues in 2012, and nearly all affected infants were diagnosed about 1 hour after birth. So it happens very quickly. Late onset GBS disease is different. This is the other kind of GBS disease. This occurs between 7 days and 3 months of age. Antibiotics given during labor do not prevent late onset GBS disease. So this disease is usually acquired from the hospital, from healthcare workers, from family members, or the community. So this wasn't something that baby was contracted in your body going through the vaginal canal. Instead, babies contracted GBS disease from community members. So this is why it's really important to wash our hands, not pass babies around. So I do know someone whose baby had late GBS disease, and the baby had to go through very intense courses of antibiotics. And because of the late onset GBS, baby has a hearing impairment. The kiddo is actually now about 10, and he has to wear hearing aids. Getting tested in pregnancy, getting antibiotics or not, none of that matters for late, and could not have prevented this and happening to her baby. Instead, it was community acquired. So somehow, someone in the community or in the hospital or where she was, who was a carrier of GBS, somehow got that bacteria on the baby. And that's how the baby was exposed, and that's how they got sick. So this is why it's really important that people are washing their hands. I know, like as a mom of 3, I've experienced relatives who are like, why can't we hold the baby and pass the baby around the room, and you want me to wash my hands? Yes, I want you to wash your hands. That could be life-saving for babies, to wash your hands. So as a birth worker, if I ever go to anyone's house, before I do anything, I wash my hands immediately. And I also make sure I wash my hands before I leave the house. So I'll be touching their doorknobs and stuff on the way to, to the sink to wash my hands at their house. Really cautious about that. And then I'm careful, I put my hair back. I'm not touching my mouth and things like that, So I highly recommend that you have everyone in your space wash their hands well if they're going to hold your baby first, with soap, the full hot water soap, the full thing. And also just limit visitors, limit passing passing your baby around the room with lots of people holding baby, right? Kissing baby on the face. We don't want other people kissing your baby or anything like that. We need support, we need community, and we also need to be careful. Yeah, so let's talk a little bit next about how early GBS disease develops. So basically, the amniotic sac, or the bag of water, provides this barrier that helps protect bacteria from the uterus. So when your amniotic sac is intact, the baby is protected from bacteria from the outside world. So after the amniotic sac ruptures, which can happen before you go into labor, and it could also happen during labor, or it could happen like when you're pushing right before baby comes out, right? Or maybe it doesn't happen and the amniotic sac is intact the whole time. That can happen too. So we just don't know exactly how it will go for you. But after the membranes rupture, bacteria now have a pathway to the uterus. So if GBS is present in the vagina, it could travel upwards into the amniotic fluid and the uterus, and this is called an ascending infection or vertical transmission. So it can travel up and could cause early GBS infection for a baby. They could inhale or swallow the amniotic fluid that has the bacteria in it, right, into their lungs. And so newborns can also come into contact with GBS on their skin, mouth, or nose when passing through the vagina. So many babies become temporarily colonized with GBS, but they remain healthy. Being colonized with GBS is not the same as having GBS disease. So let's talk a little bit next about the risks of early GBS disease. So when a pregnant person or a mama carries GBS and does not receive antibiotics during labor, research by Boyer-Godoff in 1985, along with later CDC data in 2010, found that approximately 50% of babies may become colonized with GBS, but approximately 1% to 2% of babies may develop early onset GBS disease. So this basically means that about 98 to 99% of babies born untreated with GBS carriers will not develop early onset GBS disease. So to say that again, if you have GBS, you test positive, and you choose to decline the antibiotics, there's a 98 to 99% chance that your baby will not develop early onset GBS disease. So when a GBS positive person receives an appropriate antibiotic during labor, because there are specific ones for GBS, the baby's risk for early onset disease decreases by about 80%. So even though the risk is low, it is really serious because it can cause cognitive issues long term, and it also can cause death. And so, yeah, I think it's like when we talk about antibiotics, it can feel kind of like a heavy topic because a lot of us know about antibiotic resistance. We know how important the microbiome is, and we don't want to drop a bomb on that, right? And there are harms, like negative consequences to babies when they get antibiotics in labor. But also antibiotics are life-saving, right? So we're going to talk more about this here soon. Maybe I'll just kind of share what the data says when we do use antibiotics, just looking at the population in general. So I mentioned the risk is 1% to 2% if you don't have antibiotics or you don't get antibiotics in labor. But if you do get antibiotics in labor, the risk for babies developing GBS goes down to 0.2%. So that's an example of the 80% reduction. Antibiotics that are commonly used are penicillin, ampicillin, and cefalozone. So now let's talk about the frequency of early GBS disease. So before universal screening, recommendations were widely used in the United States. The rates of early GBS disease was approximately 1.8 cases per 1,000 live births. More recent U.S. surveillance found that approximately 0.2 to 0.23 cases per 1,000 live births. And this is from Narandi and colleagues in 2019. They reported a rate of approximately the 0.23 in 1,000. So in England, where antibiotics are generally based on additional risk factors, so this is different. So rather than we're going to screen everybody and we're going to test everybody and see if they have it. If they're positive, they get antibiotics. If they're not positive, they don't get antibiotics. That's the universal screening. But in other places like England, they're using a different additional risk factors approach. And so this approach basically means that we're going to see if you're positive and we'll treat if there are additional risk factors, right? So when looking at the way that they do it, it's 0.53 cases per 1,000 births. So the rate is still low and it's still better, right, than 1 to 2% out of every 1,000. But we do find that using the universal screening where we're going to check everyone and then we're going to treat the people that are positive does result in fewer cases of early onset GBS disease rather than the other risk factor approach. The universal screening approach does not prevent every case though, and I think that's really important to be aware of because what we talked about before, like some cases occur after a negative screening result, and some cases occur when antibiotics were indicated but not administered. And some cases also occur even after antibiotics are given. So you can give antibiotics and the baby can still develop early onset GBS disease. So let's talk about long-term complications from GBS. So GBS remains a major cause of newborn illness and death in areas without reliable access to testing, antibiotics, hospitals, and emergency care. Globally, GBS has been associated with stillbirths, early onset and late onset disease, and infant death. And so Narandi and colleagues in 2019 reported that in the United States, approximately 6.9% of full-term infants with early GBS disease may die from the infection. And so the death rate is higher in premature infants at about 19.2%. And infants who survive may require a long and expensive stay in neonatal intensive care units. And possible complications include pneumonia, sepsis, meningitis, cognitive impairment, motor impairment, hearing impairment, vision impairment, and up to 18% of infants who survive GBS meningitis in middle to high resource countries may experience moderate to severe neurodevelopmental problems, according to Coley-Lynch and colleagues in 2017. So the factors that increase the risk for early GBS disease, which is really the primary risk factor, is if you've been tested positive and if you carry GBS. So the highest risk factor to be aware of is if you carry it, but there are additional risk factors to look at as well. So preterm birth, which means having your baby before your term, does have an increase in the risk. Water broken for 18 to 24 hours or longer, a fever during labor, above 100.4 degrees Fahrenheit or 38 degrees Celsius, water breaking before labor begins, chorioamnitis or infection of the membranes, a previous baby with early GBS disease, GBS found in the urine during pregnancy, intrauterine monitoring, so that's where instead of doing external monitoring where we monitor your belly to listen to the baby's heart rate, we're doing internal monitoring, so the monitors are attached to the baby's head and to your uterus. Internal monitoring does increase the risk for early onset GBS infection for babies. Membrane stripping and membrane sweeps also increase the likelihood for early onset GBS infection for babies. And giving birth for the first time. Preterm birth, fever during labor, and prolonged rupture of membranes are the most important risk factors to consider. So about 60% of newborns who develop early GBS disease have no additional risk factors other than the mom is a carrier of GBS. So this is why the other risk factors approach, where if you're positive, we're not going to test you unless we see if you have another risk factor, isn't as effective because there are some cases where there aren't other risk factors. Approaches to preventing early GBS disease is different depending on where you are in the world. So we talked about like those two approaches. So there's a universal screening approach. And so this is where you're screened for GBS near the end of pregnancy. If you test positive, you're offered the IV antibiotics during labor. The antibiotics are not needed when a planned cesarean happens before labor and before the membranes are ruptured, but it is if you're getting a cesarean and the membranes have been ruptured. And so this is used in approximately 60 countries. Countries using this approach include the United States, Canada, Mexico, Brazil, France, Germany, Spain, Australia, Japan, and others. So this approach prevents more cases of early GBS disease than the other risk factor approach. So under the other risk factor approach, moms are not really routinely screened. Antibiotics are administered during labor when certain risk factors occur, like GBS in the urine in pregnancy, a previous infant with early GBS disease, preterm labor, fever during labor, waters broken for more than 18 hours. So this approach is used in approximately 25 countries. And countries using this approach include the United Kingdom, Ireland, the Netherlands, Norway, Sweden, India, New Zealand, and others. So antibiotic use actually remains about the same. It's about 30% either approach. So the other risk factor approach results in more cases of early GBS disease than the universal screening. There's also something called a combination approach. So there are several countries or providers that might screen for GBS, but only recommend antibiotics when the person is GBS positive and additional risk factors are present. So there's limited research on this combined strategy, but because approximately 60% of babies with early GBS disease have no additional risk factors beyond just having GBS, requiring another risk factor may fail to prevent many cases. Okay, next let's talk about like the big elephant in the room I feel like that everyone is wanting to know about, which is like, what about antibiotics in labor and like what are the risks and benefits of those? So let's talk about that. Giving penicillin during pregnancy before labor was not really effective because GBS levels returned after the antibiotics were stopped. So unfortunately, we just say like, oh, at 37 weeks, we find out that you're positive. We're going to give you a course of antibiotics. By the time you go into labor, it's very possible that the GBS will have returned. So researchers studied antibiotics administered during labor. And there were 3 early randomized trials, including about 500 moms. And when GBS positive participants received penicillin or ampicillin during labor, the risk for early GBS disease decreased by about 83%. So, which is consistent with what I mentioned earlier, there's about an 80% reduction. So the randomized trials were conducted by Boyer and Goroff in 1985, Tabrian and Hallman in 1989, and Matoris and colleagues in 1991, and then later reviewed by Olson and Saha in 2013. So these studies had limitations, and they were conducted before modern clinical trial reporting standards. So researchers are really unlikely to conduct any new trials, unfortunately, without intentionally withholding antibiotics, right? So sometimes it's kind of hard to research things because we need to be ethical about how we research things. And so if we're in a situation where we want to research if we don't do antibiotics, what happens, that's not ethical because those babies could develop early onset GBS infection, and that's not good. So because existing evidence suggests antibiotics, prevent the disease, large observational studies support the effectiveness of antibiotics during labor is what we're really seeing. So the universal screening versus the other risk factor approach, let's kind of talk about that a little bit more with antibiotics specifically. So a large US study by Schrag and colleagues in 2002 reviewed more than 629,000 births. So this universal screening approach was associated with 54% of a lower risk of early GBS disease compared with the other risk factor approach in the study by Schrag and colleagues in 2002. So approximately 1/3 of moms received the antibiotics under both approaches. And so this study contributed to the United States recommending universal screening beginning in 2002. So as universal screening increased, early GBS rates decreased. So we know that antibiotics are effective. That's kind of what I'm trying to illustrate, is to have research on this, and it is an effective way to reduce the risk for GBS disease in newborns. The thing is that universal screening cannot prevent all cases because some people receive false negative test results, and some people do not receive antibiotics when it's indicated, and also some people give birth before receiving enough antibiotics. Also, a small number of babies do develop the disease despite getting the antibiotics. So the timing of the antibiotics is something that's important to be aware of. So the most effective prevention occurs when an appropriate amount of antibiotics is started at least 4 hours before birth. And so we can't always time this because sometimes we have a baby really quickly and we just, there's nothing we could do about it. That's just the way that it happened. So penicillin or ampicillin, if given more than 4 hours before birth, was reported to be approximately 89% effective. So that's really great. When given 2 to 4 hours before birth, the effectiveness was reported at about 38%. So it is protective still, but it's partially protective to get antibiotics for a shorter amount of time. If antibiotics were given less than 2 hours before birth, they're less effective than when given, at 4 or more. 2 hours of antibiotics are still going to provide some protection though. And so the way that they would administer the antibiotics would be through an IV. Medically necessary interventions should not be delayed to complete a few hours, like the 4 hours of antibiotics. If for some reason someone needs to intervene and we're like, wait, no, we need to keep doing the antibiotics, that's not a good reason not to do that, because even getting a couple hours, is showing that it is partially protective. So one study by Turrentine and colleagues in 2013 reviewed 4,000 756 births, in which antibiotics were given during labor. And the rate of newborn sepsis was about 1.4% when antibiotics were given for less than 4 hours, and approximately 0.4% when antibiotics were given for 4 hours or more. Another study by Sakasa and colleagues in 2015 evaluated GBS levels after penicillin was administered. So before antibiotics, 72% had detectable GBS. 2 hours after the first dose, 47% had detectable GBS. 4 hours after the first dose, 12% had detectable GBS. So penicillin also reached therapeutic levels in the cord blood and the amniotic fluid. So recommended antibiotics are penicillin. It's the main one. It's the preferred antibiotic. And I know that, it doesn't work for everybody because some people are allergic to penicillin. But if you're not, that's probably the one that will be offered. It has a relatively narrow range of action. And so it crosses the placenta and it reaches the fetal bloodstream at non-toxic levels, but it does get to baby. So GBS remains highly susceptible to penicillin. And then there's ampicillin, which is an appropriate alternative to penicillin. And it's basically a type of penicillin that should not be used without someone, or that should not be used with someone who has like a true penicillin allergy, because they still might react to that one. Another one is cefazolin, and that's generally recommended when a person reports a penicillin allergy but is considered a low risk for a severe anaphylactic reaction. And most people with penicillin allergies can actually tolerate cefazolin okay. Cross-reactivity may be less common than previously believed because you can outgrow a penicillin allergy. So a lot of people don't know that, but that is possible. Cefazolin does cross the placenta as well. And it has a narrower range of action and less microbiome impact than like clindamycin or vancomycin. Clindamycin and vancomycin are more intense antibiotics. Clindamycin should only be used when a laboratory testing confirms that your kind of GBS strain is susceptible. And so it needs like a more intense antibiotic. Many strains of GBS are resistant to clindamycin, unfortunately. And clindamycin does reach the fetal bloodstream less effectively. And it has not been tested in randomized controlled trials to prevent early GBS disease. So we don't know if that specifically will prevent early GBS disease. It was reported to be approximately 22% effective in one study, so not that effective. The other one is vancomycin. And so vancomycin may be used when a person is at high risk for a severe penicillin reaction and the GBS strain is resistant to clindamycin. And so vancomycin is a broad spectrum antibiotic. It has a greater effect on the microbiome and more potential side effects. So overuse might contribute to antibiotic resistance. So this is why it should be administered using strict weight-based dosing, and it should only be administered if that is the right one for you because you have a penicillin allergy and we're learning through testing for sensitivity with your strain that that's the one that we need to rate. So it shouldn't just be given to everybody. Kidney function might also need to be assessed before administration, and it should be infused slowly, generally over 1 or 2 hours, or longer for larger doses. And then there's erythromycin. And erythromycin should not be used to prevent early GBS disease because most GBS strains are resistant to erythromycin. It does not cross the placenta effectively, but unfortunately, it is not going to be that protective. So let's talk about penicillin allergy testing a little bit. So lots of adults report having a penicillin allergy and then they're no longer allergic later on. About 80% to 90% of adults who report a history of penicillin allergy may be able to tolerate penicillin later. The original reaction may have been resolved or have been caused by the illness rather than the antibiotic. So penicillin allergy testing during pregnancy may help determine whether penicillin can be used safely, and a person's previous reaction should be discussed in detail with their care provider. Okay, now let's talk about antibiotic administration and through the IV. So receiving antibiotics, it does not necessarily require being continuously connected to an IV pole. I think that's something a lot of moms are worried about. So typically the administration schedule looks like giving the penicillin or ampicillin approximately 15 minutes infusion for about 4 hours. And then the cefazolin is approximately 30-minute infusion every 8 hours. Clindamycin is approximately 10 to 60-minute infusion every 8 hours. And vancomycin is approximately 1 to 2 hour infusion every 8 to 12 hours. So depending on what antibiotic you're using, that really depends on how long you'd need to be connected. Penicillin is not very long. Between doses, the IV can be saline locked or hep locked. So that basically means that they leave that tube connected, usually in your hand, sometimes in the forearm or in your arm. And they're leaving that there and it's connected, and then they can reconnect it later. And so this basically allows the tubing and the IV pole to be disconnected, which is really nice. So you shouldn't have to you don't need to carry that around. The IV should not necessarily prevent you from walking, changing positions, laboring in the water. And the IV site might need to be protected before entering water. So you might need to put something over it. And that's something that you can ask about. Some moms just try to labor in the water with their arm out or their hand out, and that usually works okay. So now let's get into the benefits and the risks of antibiotics during labor. The potential benefits include reducing the risk of early GBS disease by approximately 80 to 83%, preventing GBS from growing in the baby, reaching the fetal bloodstream right through the placenta, reducing early GBS disease rates more effectively than relying on the additional risk factors. So that means we're going to give antibiotics only if you have other risk factors. And then using antibiotics, especially penicillin, to which GBS usually remains susceptible. So now let's talk about the potential harms of antibiotics. And so possible harms include allergic reactions, rare anaphylaxis, nausea, vomiting, diarrhea, rashes, decreased appetite, yeast infections, effects on maternal microbiome, and effects on the newborn's microbiome. Increased medicalization through the IV placement and medication administration, and contribution to antibiotic resistance. So in one large study in Texas by Mula and colleagues in 2010, involving more than 700,000 births, 19 cases of anaphylaxis were identified. So this is pretty rare, but it can happen. 5 were attributed to penicillin. 6 were attributed to cephalosporins, and there were no deaths. Yeast infections is another thing that I wanted to talk about. So antibiotics kill beneficial bacteria as well as harmful bacteria. And that's kind of the trade-off with antibiotics, unfortunately. And so when killing good bacteria, this might allow yeast to grow. So a postpartum parent may experience red or painful nipples, breast or nipple yeast infections, and a baby could experience thrush or a painful or inflamed mouth. And so in a study by Dismore and colleagues in 2005, approximately 15% of people who received antibiotics during labor developed a postpartum yeast infection. So approximately 7% of those who did not receive antibiotics experienced this outcome. So it does increase with antibiotic use. The microbiome is essentially an ecosystem of bacteria, like fungi, viruses, and other microbes that live on or in your body. So microbes are found in all areas, including skin, intestine, rectum, the nose, the mouth, the genital tract, the urinary tract. Some bacteria are beneficial. Beneficial bacteria supports our digestion. It supports our energy, supports brain activity, emotions and behavior, vitamin production, and drug metabolism, immune protection, protection against infections. So we need these guys, we need the microbes, and the microbiome begins developing before birth, but much of it is established during and after the birth. So your baby going through the vaginal canal, your baby skin to skin, licking your chest, getting that bacteria, all of that is supporting them in creating their microbiome. A vaginal birth exposes the baby to bacteria through the genital tract, and a cesarean birth exposes the baby to a different pattern of microbes. So babies born vaginally tend to have more beneficial bacteria early in life than babies born by cesarean. So the microbiome continues changing during the first 3 years of life. And after approximately 3 years, it becomes kind of more stable. And so what we found is that breast milk or human milk actually has an impact on the microbiome. And this plays into the whole antibiotic GBS thing, which we'll talk about soon. So basically, breast milk contains antibodies, immune properties, oligosaccharides, and then basically oligosaccharides feed beneficial bacteria. So oligosaccharides are kind of like prebiotics, they feed the bacteria, and they also make it harder for harmful bacteria to establish themselves in the infant's gut. So human milk or breast milk may reduce some negative microbiome effects associated with antibiotics. Antibiotics do affect your baby's microbiome. Research has found that antibiotics given during labor can temporarily reduce beneficial bacteria, reduce microbiome diversity or richness, increased potentially harmful bacteria, and 8 of 9 reviewed studies found at least a short-term effect. So some studies found that the microbiome recovered or mostly recovered within 4 to 8 weeks. Other studies found that there are differences in the babies who had antibiotics lasting 3 months or in some infants up to 1 year. A Canadian study by Azad and colleagues in 2016 followed 198 infants. And at 3 months, infants exposed to antibiotics had lower levels of beneficial bacteria, reduced microbiome richness, and the greatest difference occurred in babies born by cesarean. So by 1 year, most differences had resolved. Some effects remain in infants born by unplanned cesarean who were not fed breast milk for at least 3 months. So the long-term immune effects of temporary microbiome changes is not yet known. So we just don't know. So I wish I could talk about that, but I can't because we don't know. The microbiome impact might be lessened by having a vaginal birth and by breastfeeding your baby or feeding your baby human milk. So clindamycin and vancomycin may have a greater microbiome impact than penicillin, ampicillin, and cefalozone. Next, let's talk about probiotics. So probiotics, specifically lactobacillus, have been studied as a way to reduce GBS colonization. So lactobacillus basically makes the vaginal environment more acidic, which may inhibit GBS growth. So a meta-analysis by Hansen and colleagues in 2022 suggested that probiotics might moderately reduce positive GBS results. However, 5 of the 6 studies were at high risk for bias, and more rigorous randomized trial by Hansen and colleagues in 2023 came out. It's just small though, but it included 103 moms. And participants began a probiotic or placebo capsules at 28 weeks and then continued until labor. And GBS swabs were then collected at 28 weeks and 36 weeks. And so 83 participants ended up completing the whole study, and the probiotic group experienced fewer gastrointestinal symptoms, but there's no difference in GBS positive test rates at 36 weeks. So participants took the assigned pills approximately 51% to 60% of the time, and so no adverse health outcomes were reported. The evidence on probiotics to prevent GBS colonization is unfortunately not super clear. Probiotics can help reduce digestive symptoms during pregnancy, we found, so that's cool. But no study cited in the supplied information found harmful effects on moms taking probiotics for this purpose. Chlorhexidine and hibiclens is the next thing I want to talk about. So chlorhexidine is basically a topical disinfectant. Hibiclens is a brand that contains chlorhexidine. When applied to the vaginal area, it basically has an effect against GBS that lasts 3 to 6 hours. So we're kind of talking about those alternatives to antibiotics and other options. We talked about human milk, how that can help with reducing the harmful effects of the antibiotics for GBS. Vaginal birth can. Probiotics, can it, reduce GBS? We're not saying that it does, but we are seeing that taking antibiotics can help, or taking probiotics can help with digestive issues. So the next one is the hibiclens. So a Cochrane review by Olson and colleagues in 2014 included 4 randomized trials with 1,124 infants born with GBS positive parents. So the quality of the evidence was considered low. And basically they found that chlorhexidine, it did not reduce newborn GBS colonization or early GBS disease. So the chlorhexidine group experienced more stinging and vaginal irritation. Observational studies in Egypt and Malawi used chlorhexidine in the vagina during labor and wiped it onto the newborns after birth. And those studies reported reductions in newborn hospital admissions and sepsis admissions and deaths related to infections, but the studies did not specifically measure GBS disease and were not randomized trials. So we don't really know if that's a super effective alternative. Chlorhexidine may provide some benefit in low resource areas where antibiotics are available. It has not been shown to be effective, though, as a replacement for IV antibiotics in more high resource settings. So the next thing I want to talk about is garlic. Garlic has antibacterial properties. 2 laboratory studies found that garlic or compounds from garlic inhibited or even killed GBS in petri dishes. So these studies were conducted by Coulter and colleagues in 2009 and Torres and colleagues in 2021. Garlic has not been tested in a pregnant person as a vaginal treatment for GBS. I do know people who put garlic in their vagina to clear GBS, but we don't have research on that. Any reduction in GBS could also be temporary. You could be tested positive, and then you could take garlic, and then you could be tested negative, but then it could come back, Unknown risks include premature rupture of the membrane, so that could maybe happen if you put garlic in your vagina, or damage to beneficial vaginal bacteria, which also can cause, when we mess with the microbiome, that can sometimes cause issues, and growth of other harmful bacteria. Also, like irritation or unexpected effects is also a possibility. Putting garlic in your vagina might not feel good. So there's not enough evidence to say whether we can safely or effectively insert garlic into the vagina to help us, unfortunately. I wanted to talk about breast milk again, though, because there was another study that came out that's really interesting about the oligosaccharides in human milk or breast milk as a topical treatment for GBS. So human milk contains about 100 types of oligosaccharides. And so these compounds basically feed beneficial bacteria, like I talked about before. They block harmful bacteria from establishing themselves, and they do influence immune function. They support brain development. So laboratory research found that human milk oligosaccharides inhibited GBS in petri dishes, which is really interesting. And so a mouse study by Majaya and colleagues in 2002 found that topical application inhibited GBS in the vagina without disrupting the rest of the vaginal microbiome. And so this treatment has not been studied in pregnant people. It remains an area for future research, but I think it's interesting that we're finding that. The next is colloidal silver. No research studies have established if it's safe to take colloidal silver or use it in pregnancy. In 1999, the U.S. Food and Drug Administration stated that colloidal silver is not safe or effective for any condition. Researchers have reported serious toxicity and health risks, so be aware. But some people have talked about using colloidal silver for GBS, so that's kind of where we're at with that. Yeah, and then, there is also a GBS vaccine, and so maybe I'll just, coming out potentially, so I'll just talk about that a little bit too. Researchers are developing vaccines because antibiotics don't prevent every case of early GBS disease. And antibiotics can affect the microbiome, and they do not prevent late onset GBS disease. Antibiotics do not prevent all GBS-related stillbirths or preterm births, so testing and IV antibiotics might be unavailable also in low-resource areas. So an analysis by Seeley and colleagues in 2017 estimated that a vaccine with 80% effectiveness given to more than half of moms worldwide could prevent about 23,000 stillbirths and about 127,000 cases of early GBS disease, approximately 37,000 infant deaths each year. So there are companies that are working on a GBS vaccine currently, and that's not out yet. And so we'll have to kind of watch that and follow that and see how things change, over time. It sounds like, kind of based on what I'm saying and what I've shared today, there are a lot of options that are not yet explored, right? Like using the breast milk and the garlic, right? And so this is an area that over the generations we'll probably see shifts in recommendations and shifts in what's available. So kind of to summarize what we talked about today, I know that was a lot of information. Today was a really information heavy training, but I hope that this was helpful. I'm going to post this video training. If you're listening on Instagram, click the link in my page, and then you can join my Peaceful Birth Academy for free, and I'll upload the video training there. For those who are part of that already, I'll post it in 1 to 2 weeks. And so you're welcome to access this. Evidence-based birth is also a really great resource to illustrate the research if you want to learn more now. Maybe I'll just share my personal story with GBS, which was that I tested negative with my first, I tested positive with my second, and positive with my third. I personally chose to decline the antibiotics, knowing what I knew then. Because I knew that the risk for early GBS disease was very, very low. And I decided that if I had other risk factors, I would consider it, but I didn't end up developing other risk factors. Yeah, and my babies were fine. And I, monitored them. I monitored their temperature and really watched every hour unless I was sleeping. I was taking their temperature for that first week of life and really looking for those signs. If anyone chooses to decline antibiotics, it's important that you're counseled and you really understand what are the risks for baby showing signs that they're developing an infection or they're not okay. Because it can be kind of confusing with a newborn, because newborns, they are, I don't know, what is normal might seem like it's not normal, and what's not normal might seem like it's normal. So like, for example, babies being really sleepy, that's normal, but it's also a sign that baby isn't doing well. So there are like clarifications you can get. And if you're in my coaching program, you'll really learn in depth all this stuff. And there I kind of go over all of this, but I recommend talking to your provider to really help you understand like what are the things I need to look out for if I choose to decline. Choosing to get antibiotics is an evidence-based way to reduce the risk of early GBS disease for your baby. There are consequences to taking antibiotics as well. And so this is really a personalized decision. It's not a decision for you to make, like just because someone told you to do this thing and you're like, okay, whatever, I'll do it. It's more about like understanding the research, understanding your intuition and your instincts and how you feel, and making a decision from that place, because it is a big decision. And also what might be the right decision for one person might not be the right decision for another person. So just because I chose to decline with my babies before, it doesn't mean that I wouldn't always decline, because in the future I might choose to consent to that if circumstances felt different for me. So yeah, it's different for everyone. I hope this was helpful information. Thank you so much for being part of this training today, and I'll let you go. Have a good day. My private coaching clients have outcomes 9 times better than the national average, and they followed my 5-step process to support them in having a peaceful birth. So click the link below to access the same 5-step framework that we use to get these results. You've got this. Click the link below to book a free birth breakthrough session with me. This is a free one-on-one call where I will give you clarity on the steps needed for you to go into birth feeling confident and prepared, and explore how I can support you.